Welcome to Pediatric Case Review. Today's lecture is a comprehensive case-based review of choanal atresia and the charge association designed for general pediatricians. Choanal atresia is one of the classic neonatal airway emergencies, and roughly half of affected infants carry a broader syndromic diagnosis, most often charge. Across the next cases, we will cover anatomy, clinical presentation, the bedside catheter test, embryology, imaging, the composition of the atretic plate, syndromic associations, acute and surgical management, charge diagnostic criteria, and feeding complications. Let us begin. Question 1. A 2-hour-old full-term neonate is noted to have intermittent cyanosis during quiet breathing and feeding. The cyanosis resolves promptly when the infant cries. On examination, there is no audible air movement from either nostril. What is the most likely diagnosis? Option A, laryngomalacia. Option B, bilateral choanal atresia. Option C, unilateral choanal atresia. Option D, transient tachypnea of the newborn. The correct answer is option B, bilateral choanal atresia. Neonates are obligate nasal breathers for roughly the first 4 to 6 weeks of life, so any complete blockage of both posterior nasal passages causes immediate respiratory distress at rest. The hallmark sign is paradoxical or cyclical cyanosis. The infant turns blue and struggles during quiet breathing or feeding, but turns pink the moment they cry because crying forces them to breathe through the open mouth. Unilateral atresia usually presents much later in childhood with persistent one-sided nasal discharge and obstruction, not acute cyanosis. Laryngomalacia produces inspiratory stridor, and transient tachypnea of the newborn causes tachypnea and grunting, not cyclical color change. Question 2. A 6-hour-old neonate with suspected nasal obstruction is being evaluated. The attending physician wants to perform a quick bedside test to confirm the suspicion of choanal atresia before ordering imaging. The infant is stable with an oral airway in place. Which of the following is the most appropriate initial bedside test? Option A, nasal endoscopy. Option B, flexible laryngoscopy. Option C, attempting to pass a 6 French catheter through each nostril. Option D, high-resolution computed tomography scan of the sinuses. The correct answer is option C, attempting to pass a 5 to 6 French catheter through each nostril. If the catheter cannot be advanced beyond about 3 to 3.5 centimeters into the nasopharynx, choanal obstruction is confirmed. This test is fast, simple, requires no specialized equipment, and can be repeated at the bedside. A useful alternative is the cold mirror or dental mirror fogging test, where absence of fogging under the nostrils suggests obstruction. Nasal endoscopy is the gold standard for direct visualization, but requires ear, nose, and throat expertise. High-resolution computed tomography is reserved for definitive anatomical assessment and surgical planning, not for initial screening. Question 3. A medical student is reviewing the embryology of a neonate diagnosed with choanal atresia. The choanae normally develop between the 3rd and 7th weeks of embryonic life. The student is asked about the underlying embryological mechanism. Choanal atresia is primarily thought to result from the failure of which embryological structure to rupture during fetal development? Option A, buccopharyngeal membrane. Option B, first pharyngeal arch. Option C, frontonasal process. Option D, primary palate. The correct answer is option A, the buccopharyngeal membrane, also called the nasobuccal membrane of Hochstetter. This membrane normally ruptures between the 3rd and 7th weeks of embryonic life to establish communication between the developing nasal cavity and the nasopharynx. When rupture fails, persistent tissue blocks the posterior choani, producing atresia. Other proposed mechanisms include incomplete resorption of nasopharyngeal mesoderm and misdirected migration of neural crest cells. The resulting atretic plate is composed of bone in approximately 90% of cases and pure membrane in about 10%, although mixed bony membranous lesions are by far the most common in practice. Question 4. A 1-day-old neonate with bilateral choanal atresia has been stabilized with an oral airway. The ear, nose, and throat team is consulted and plans surgical intervention. They need to determine the exact composition and thickness of the atretic plate to plan the surgical approach. Which of the following is the most appropriate imaging study? Option A, lateral neck X-ray. Option B, high-resolution computed tomography of the skull base and sinuses. Option C, magnetic resonance imaging of the brain and face. Option D, barium swallow study. The correct answer is option B, high-resolution computed tomography of the skull base and sinuses. This is the gold standard imaging modality for choanal atresia because it clearly distinguishes the bony from the membranous components of the atretic plate. Typical findings include a thickened voma, narrowed posterior nasal cavity, and medial bowing of the pterygoid plates. Suction of nasal secretions before the scan improves accuracy. Magnetic resonance imaging is reserved for situations where an encephalocele or skull-based defect is suspected. Plain X-rays and barium swallow studies have no useful role in evaluating choanal atresia. Question 5. A 3-week-old infant with unilateral nasal obstruction undergoes high-resolution computed tomography scan. The scan reveals a complete obstruction of the right posterior choana. The radiologist describes the composition of the atretic plate in the report. What is the most common composition of the atretic plate in choanal atresia? Option A, purely membranous. Option B, fibrous tissue only. Option C, mixed bony membranous, predominantly bony. Option D, cartilaginous. The correct answer is option C, mixed bony membranous, predominantly bony. Approximately 70 to 90% of atretic plates are of this mixed type, with the bony component dominating. Pure membranous atresia accounts for only about 10% of cases. The bony component typically involves a thickened voma and bowed medial pterygoid plates, while the membranous portion forms a thinner soft tissue layer. Knowing the composition matters for surgical planning because thick bony plates require drilling, while membranous lesions can be opened more easily. Pure cartilaginous atresia is not a recognized category in the standard classification. Question 6. A newborn diagnosed with bilateral choanal atresia is undergoing a comprehensive evaluation for associated anomalies. The neonatologist explains to the parents that choanal atresia frequently occurs as part of a broader syndromic condition. What approximate percentage of infants with choanal atresia have an associated syndromic condition? Option A, less than 10%. Option B, approximately 25%. Option C, approximately 50%. Option D, over 95%. The correct answer is option C, approximately 50%. Roughly half of infants with choanal atresia have an associated syndromic condition, which is why every neonate diagnosed with choanal atresia must undergo a thorough syndromic evaluation. Charge syndrome, caused by mutations in the CHD7 gene on chromosome 8q12, is the single most common association. Other important syndromes include Crouzon syndrome, linked to FGR2 mutations, DiGeorge syndrome, linked to the 22q11.2 deletion, Treacher-Collins syndrome, linked to TCOF1, and Pfeiffer syndrome, linked to FGFR1 or FGFR2. Early recognition allows timely multidisciplinary management and accurate family counseling. Question 7. A full-term neonate is delivered and immediately develops severe respiratory distress with cyanosis during quiet breathing. Bilateral choanal atresia is confirmed at the bedside. The infant is desaturating to 70% on pulse oximetry during quiet breathing but improves to 95% when crying. What is the most appropriate immediate management? Option A, immediate tracheostomy. Option B, placement of a nasopharyngeal airway. Option C, insertion of an oral airway or McGovern nipple. Option D, emergent surgical repair of the atresia. The correct answer is option C, insertion of an oral airway, often called a McGovern nipple. This is a modified nipple with the tip cut off, placed in the mouth to break the seal formed by the tongue against the palate. By keeping the mouth open, it allows oral breathing and bypasses the blocked nasal passages. It is simple, rapid, and highly effective as a first-line emergency intervention. A nasopharyngeal airway will not work because the posterior choanae themselves are blocked. Tracheostomy and emergent surgery are not first line. The priority is to stabilize the airway, then obtain a computed tomography scan, then plan definitive endoscopic repair when the infant is optimized. Question 8. A 10-day-old infant with bilateral choanal atresia has been stabilized with an oral airway and is now scheduled for definitive surgical repair. The ear, nose, and throat surgeon discusses the surgical approach with the family. Computed tomography scan shows a mixed bony membranous atretic plate bilaterally. What is the current gold standard surgical approach for choanal atresia repair? Option A, transpalatal approach. Option B, transeptal approach. Option C, transmaxillary approach. Option D, transnasal endoscopic approach.